let people sign in. Give it one more minute. All right, I think we'll go ahead and get started. I want to welcome our speaker, Kaitlyn Mosher. And just one second, I'm gonna lost my place. And we're so happy to have Kaitlyn here to talk about feeding is among children with ASD. And I was just telling Kaitlyn that we're doing a health intervention for Latino families of children with ASD and other IDDs. And this is the biggest issue that the parents bring up is like, if we're going to have our kids eat healthy foods, how do we get them to even expand, what they're interested in eating? So really excited about this. And just tell you a little bit about Kaitlyn. She's a pediatric psychologist in the Department of Pediatric Psychology and Neuropsychology and the Comprehensive Pediatric Feeding and Swallowing Program at Nationwide Children's Hospital. She's also clinical assistant professor of pediatrics at the Ohio State University College of Medicine, and she provides evidence-based assessment and intervention services for children with feeding difficulties due to medical and developmental complexities, environment, and psychological factors in the intensive day treatment program as part of an interdisciplinary team, as well as in multiple outpatient roles. And both their clinical and research interests focus on feeding treatment with children with ASD and other developmental disabilities, and the role of parent-child interactions in feeding and impacts of feeding difficulties on development. So I want to welcome you, Dr. Mosher, to the Autism Consortium of Texas, and we're really excited to have you here.
Awesome. Well, thank you so much. And I'm very excited to be with you guys today. It's a great way to end my Friday. So today I'm going to be talking about the impact of improving feeding on general development for children with ASD. It is primarily focused a little bit on some of the background, and we'll go through talking about feeding disorders within the context of autism, and a little bit more generally other developmental disabilities, and then talking a little bit about the research that I'm currently doing on the improvements that we're seeing on development from treating feeding. Not necessarily going into like how to, but absolutely at the end, I am happy to answer more specific questions, a little bit more about what feeding treatment may look like, and hear your all thoughts as well. You're also welcome to ask questions as we go. I want to give you a little bit of information about what we'll be talking about, and then a few disclaimers. So one thing that I know from currently like the literature and then working with lots of patients is, and that you guys are probably familiar with, is the terminology between first person first language and autistic person. My parents and children that I work with prefer different identifiers, and so I'll be using them interchangeably, but I just want you guys to know that typically I would ask my patients and go from there. We're going to be, the learning objectives for today is the first one to become familiar with the relevant literature on feeding challenges within the context of autism. And then identifying the ways in which feeding treatment can impact overall general development as well as parent-child relationships. So we're going to be looking at feeding through kind of a parent-child relationship lens related to some of the research that I'm doing, and then identifying practical applications of some of the information we go over today for feeding assessment, treatment, and referrals. So just a little bit about me before we get started, so you know a little bit of my background. I completed my graduate training at the University of Nebraska in Lincoln, Nebraska, and my background was actually in school psychology, but I had pediatric experiences while there at Children's Omaha. I also worked in an autism clinic for toddlers, and that's when I got some of my first, a little bit of introduction to the feeding world and how complicated it can be with children with autism. And then I completed my internship at Texas Child Study Center in Dell Children's. And so that's my connection to where y'all are at. I did some rotations in developmental behavioral pediatrics. And throughout my training in graduate school and internship, I continued to do parent-child interaction therapy, which was one thing that I really loved, and other parent training programs. And then I completed my fellowship at Nationwide Children's here in Columbus, Ohio, specifically in the feeding program, which combined like all of the things that I love as far as parent training and coaching and the populations that I love to work with autistic children and children with other developmental concerns. And then I am now faculty at Nationwide Children's, really within the same realm that I was doing with fellowship training, so working within the feeding clinic. So happy to talk more about where I got to where I am, if that is of any interest to anyone. So in the Comprehensive Pediatric Feeding and Swallowing Program, we provide a lot of different services. We do team evaluations, so where there's multiple medical provider, dietitian, psychologist, evaluate a child's feeding and then make recommendations from there. We also have medical management, so where children come for their follow-up medical appointments related to feeding. We do outpatient services, psychology, feeding therapy, and then feeding therapy from like an OT or speech provider. And we do a co-treatment program, which is a more formal. It's 8 weeks. A child comes one time a week, and then they meet with both psychology and feeding therapy, which again is either a speech language pathologist or an occupational therapist who's specifically trained in feeding. And that's a program that I participate in as well. And then we're probably what we're kind of most well known for at the hospital is our intensive feeding track. And this is where, I guess I'll go into it more on this side. It's an 8-week intensive intervention for feeding difficulties. Children come for 3 meals a day with their caregiver, and the first meals, like the first few weeks, meals are completed with the feeding therapist as the one conducting the meals, and the caregiver is observing and learning and doing a lot of other things. And then the caregiver is transitioned into the meals and starts conducting the meals with a lot of coaching. They do bug in the ear coaching. So if you're familiar with PCIT, it's actually kind of similar, but with feeding. And the child doesn't necessarily stay there all day, but they can. They have like a room that they're able to stay in during the day in between meals if they want to. And then the treatment team consists of a feeding therapist, a psychologist, a medical provider, a dietitian, and a social worker. And then we also have other members of the team, like our chef that prepares the meals, a child development specialist, and a few other people as well. The parents and caregivers during this time, they attend psychology meetings with the psychologist. They attend family meetings as a whole team once a week. They're trained in the feeding protocols and all of the behavioral management for meals, and they learn the meal preparation skills for what their child's eating, whether they're learning how to make high-calorie purees or they're learning how to make some of their own family meals into food that is appropriate, whether it's texture or whatever for their child. What we do as psychology as part of the team is we really support the caregivers. There's a lot of anxiety, a lot of stress. A lot of the patients we see are former NICU patients, which comes with parents with a lot of different stressors and anxiety related to their child's care. We help with the caregiver training and their understanding of the behavioral principles and applying them. We help parents with their goals and really prioritizing them and kind of realistic expectations. Parents often come in with, well, I want my child to be eating typically. And that means maybe being able to go to a restaurant, being able to eat the family meal, having no behavior at meal times. And so while we want to help them see the big picture and what we're working towards, it's also important to help them focus on really these 8 weeks. What are we really going to target during our time here? Psychology is really helpful with the transition home, the generalization, problem solving. Parents start doing meals at home once they're fully trained in the program. So then they go home each night, they record the meals that they're doing at home, and come back the next day and get coaching on that. We're supporting parents and caregivers like agreement on being on the same page as another caregiver or grandparents or things like that. And then we're also helping with general developmental skills, parenting skills. We help a lot of times with potty training, just general tantrums, other types of skills while they're in the program. And this will be important later, but we do ask that kids pause their other therapies, like if they're in PT or OT, speech, things like that, and don't go to school during this time, which I know is a lot to ask a family, but it is really important. We found that when children try to do, number one, schedule-wise, they're not able to do all of those things, and when they try to do some of them, they get less quality from the feeding program because it's just so much work that they're doing 3 times a day. So this is kind of their main job that they're working on for these 8 weeks. So I do want to take a second and for you to just reflect on and just think about how you personally view feeding difficulties when you hear the term feeding difficulties or feeding disorder, maybe what comes to your mind. This can be so broad for each person, depending on really what professional context they're in. If you work with a lot of children with autism, then you probably have maybe a certain image that comes to your brain when you hear feeding difficulties. If you were in the NICU, you would have a totally different view of what feeding difficulties look like. If you're a parent of a toddler, you might have a different view of what feeding difficulties look like. So this ranges a lot by person, but I'm just kind of want you to reflect for the next few seconds on kind of what does feeding difficulties look like for you, and that might change over the course of the presentation too. So what is pediatric feeding disorder, PFD? This is actually a really new diagnosis. So this was only officially a medical code as of 2021, I believe. And what it means, what the kind of general description is impaired oral intake that is not age appropriate and is associated with medical, nutritional, feeding skill, and or psychosocial dysfunction. So this can be a bunch of different things, which is what these pictures kind of represent. So we could have a 6-month-old baby with an NG tube because they're showing signs of aspiration when they're drinking their bottle. That would be PFD. We can have a child with autism who only eats 3 foods and their chewing skills are totally fine, and they don't have any negative history of eating, choking, anything like that, but they just only eat 3 foods. That would be PFD. We can have a teenager who had a choking experience and now is terrified of eating solid foods and is only drinking a supplement. That would be PFD. So all of those things would be pediatric feeding disorder. And they have very different presentations, but that's kind of the point, is that the only really other diagnosis that used to capture this was ARFID, avoidant and restrictive food intake disorder. And that is technically classified under eating disorders. But it didn't capture very well. Number one, it alludes to this, like, the treatment for it is this behavioral health, psychology, psychiatry type of treatment. So very like one discipline. And it really just didn't make sense for people to be giving a mental health diagnosis to a 5-month-old that wasn't consuming enough volume by mouth. That didn't capture their symptoms very well. And it didn't take into account some of the medical complexities that come along with PFD. So a child with a heart condition is going to be very likely to have feeding difficulties, and that doesn't capture that child with an ARFID. So PFD lends itself a lot better to a multidisciplinary approach and looking at it from a multidisciplinary lens, meaning medical, nutritional, oral motor skills, all of these different pieces combine to, to end up having a child with feeding disorders sometimes. And the prevalence of PFD is about 25% of the typically developing population, about one in four. And so it's a pretty high percentage. And it ranges. So up to, that's my next one, up to 80% of children with developmental delays have a feeding disorder. And you'll see different numbers. You'll see it range from 60 to 80 or, 50 to 75. There's a lot of ranges, and that's essentially comes down to the fact that we haven't had great definitions of it in the past. And so, but the takeaway though is a lot of children, most children with developmental delays have feeding disorders, which is pretty significant. There's really no differences across race, ethnicity, SES. Like it really does affect people pretty equally. And the key about PFD, same with ARFID, there's no focus on or concern about appearance. So it doesn't fit well under an eating disorder because it is completely different mechanism. And if you treat it similar to treating an eating disorder, it won't be very effective. Let's see. So what feeding, I kind of alluded to this, but feeding difficulties are often associated with medical concerns. So reflux, EOE, which is like inflammation, kind of allergy of the esophagus. Constipation is a really big one. It's a really big one for autistic children. Prematurity is a huge risk factor for feeding difficulties, not only right then, but also later on. And then cardiac concerns are very highly associated with feeding difficulties. And then we have all of the developmental, neurodevelopmental disorders, autism, Down syndrome, CP. Some of these can be due to like motor challenges. You can, CP, Down syndrome. There's a lot of difficulties due to like the way that their tongue like thrusts forward, and often they're expelling foods more often, along with some of the other aspects that can make feeding challenging that are more associated with like the developmental aspect. And then you could have a typically developing child that just has some oral motor challenges or weak chewing or difficulty swallowing. You can have that with any of these things as well. And then 3 to 5% of all children's hospital admissions are for failure to thrive, which is where a child is not gaining weight as expected. So some common feeding goals we often have, feeding goals you'll see parents want to have. Some of the biggest ones, these are sometimes prioritized, but weight gain, so increasing the volume of their food and drink or consumed orally. Avoiding feeding tubes or weaning from a feeding tube is a really big one. So we have a lot of kids who have NG tubes, so tubes through their nose, and parents are wanting to avoid having a permanent G tube placed. And then it's important to know that there doesn't have to be a weight concern, though, for there to be a pretty significant feeding concern or a feeding difficulty. So oftentimes for kids with autism, there isn't a weight concern. Sometimes they're really high on the growth chart, and that might be because all they're doing is drinking Pediatric, chocolate milk, or eating really highly processed foods. But that definitely doesn't mean that they're meeting their nutritional goals or things like that. So other goals include decreasing dependence on formula or supplement. Increasing variety is a really big one. Increasing chewing or textured, or some kids are very stuck on purees, and increasing to table foods is really challenging. And then self-feeding or other age-appropriate skills, so drinking from a straw cup or things like that. And then decreasing negative behaviors related to feeding is obviously a really big one. Meal times can cause a lot of stress, and there are a lot of behavior problems associated with meals. Interestingly, that's not often what parents like talk about, because I think they've come up with some ways to avoid some challenging behaviors. But as soon as you put kind of structure in place or start changing things, you're going to see a lot of behaviors, and that is very stressful for parents. So moving on to intervention, behavioral interventions for feeding are typically the most effective, and they typically target feeding issues, combining a variety of behavioral strategies, but typically it's some type of meal structure. and then having consequences. So rewards, reinforcement, differential reinforcement, and then also having escape extinction, which essentially just means that we're not allowing the child to easily avoid the thing that's challenging. And then the other piece that's really important is that we're also manipulating the antecedent. So we're also changing the expectation so that it's appropriate. So we're increasing the reinforcement, increasing hopefully their motivation to want to engage in what we're asking them to do, but we're also making it so that we're reducing the size of the challenge. So we're probably going to be expecting a smaller bite of food to be consumed, or maybe we're changing the food texture so that it's easier, or we're starting with a crumb of a food instead of what parents are trying with getting them to eat a whole piece of pizza or something like that. So we're changing up the way that it is right now. And then comprehensive intensive programs can positively impact parent stress levels, and behavioral feeding interventions have a positive effect on perceptions of a child's emotional and behavioral functioning, as well as maternal parenting stress. So when parents are engaging in these behavioral feeding interventions, they typically are, the research is showing that they're feeling less stressed, and they're changing how they feel about their child's emotional and behavioral functioning as well. So we're going to go into the parent-child relationship really quickly, just generally, so that we can get into the parent-child relationship within feeding. So just generally, parent-child relationship, we've got a combination of behaviors, feelings, and expectations that are unique to a particular parent-child dyad. And research shows that there's a lot of positive qualities that are associated with a lot of great outcomes for children. So with this, we have warmth and affection, we have positive communication, we have setting boundaries and limits, family routines and structure, consistency. And these are connected to things like adjustment, self-esteem, positive behavior, and improvements in achievement and development. And the kind of theory of why this one theory of why this happens, or how parent-child relationships really impact a child's development, is related to kind of the flow of information. So if you have a parent-child quality relationship where a child's able to engage with the parent's talking to the child can ask questions or explore, then you have this improvement in social competence, you have information going back and forth, the child can learn more, and then also the child's willing to approach and persist hard and challenging things because they have all of this kind of consistency. They know how their parent's going to respond. They have the warmth and acceptance. So the child's able to persist with things that they might not otherwise, and approach things that are scary. So now if we look at feeding through this same lens of this parent-child relationship or a dynamic, then that can change a little bit of how we treat it and how we view it and assess it. So if we go back to the very beginning, so we're going to talk about babies. We right after a baby's born, very quickly we are moving into feeding. It's one of the first things that happens. And we tend to think of it, and I mean, I tended to have thought of it as just, it's like a task, it's an activity, it's like a daily living task. But really, feeding is a dynamic relationship between the baby and their caregiver. And this is a fundamental, one of the very first social interactions or exchanges between an infant and a parent. And there's a lot of cues and a lot of back and forth communication actually with feeding. And when both the infant and the caregiver are responsive to the other one, then bonding occurs, and we're laying the foundation for successful feeding experiences moving forward. So when the parent is gentle and calm, and the baby is looking at them, and the parent is reading the baby's cues as far as them opening their mouth or pulling away from the bottle, all of these different things, that is really the key to kind of starting some successful feeding experiences. However, if we have feeding difficulties for whatever reason, for like the baby just has different feeding difficulties, they're not able to swallow or drink efficiently, all kinds of things can happen early on, but this stress can really impact that first interaction, and just generally feeding interactions. If we constantly have this stress and feeding difficulties, it can really impact the parent-child relationship and kind of the family as well. And I thought this was an interesting quote from a study in 2010 from a parent who was talking about the experience after the baby was born in the hospital. So this mom said, you need to have that time alone holding them to get that bonding, because even the first feed, they watch to see what's happening. Whereas to you, that first feed is supposed to be a bit of a cuddle and a squeeze, and I'm your mom and you're my baby. But it's not to the hospital staff. It's, is she getting enough? Are things working? So I thought this was kind of interesting because it's showing that parent perspective of what they might anticipate feeding looking like and what it might be like for medical providers and what it might feel like for a parent. And I think this is only, exacerbated when we're talking about a baby in the NICU or a baby with low birth weight or other health concerns. So the research really shows that feeding difficulties impact family stress, parent stress. Um, maternal stress and anxiety during pregnancy is connected to preschool picky eating. More maternal stress was evident in mothers of tube-fed babies or children relative to children with other disabilities, other health concerns, developmental disabilities. So it's really interesting to see how much stress, like tube feeding your child differently can cause for parents. Um, Maternal feelings of stress, guilt, family conflict, not trusting healthcare professionals, feeling like other people didn't view them as competent, were some themes from interviews of moms of children with feeding difficulties. So there's a lot of different kind of feelings that parents experience, and I can speak to this just qualitatively. Parents coming in feeling like they are failing their child if they're not able to feed them, which is really sad. And I think that some things are changing. I love this picture as far as how we view and support parents feeding their child in a lot of different ways, but yet some of these things remain. And if you think about if you have had any experiences in the NICU, a lot of times feeding is the thing that keeps a baby from going home. They're ready to go home, but they're not feeding well. And so that can set up a really like adversarial relationship with feeding from the very beginning, is like this feeding is the thing that's preventing our family from being together, and that can feel super frustrating. So a little more on the interaction. So mother, and kind of on that NICU theme, mothers with babies who were born earlier and spent more time in the NICU were more likely to ignore their infants' communications in favor of accomplishing feeding. So again, kind of going back to it's this pressure, it's the stress to feed your child, to get in the calories and the volume. And so that pressure, that stress can really cause, not necessarily cause, but like also could cause or add to the already maybe difficult relationship that that child has with feeding. So it can make it even worse if there's now this like stress around it. And the child is feeling like not trusting of the parent. Like for example, these were quotes from one of the studies as well. But a parent said, sometimes I have to pull his mouth open, and sometimes he'll have his tongue on top of his mouth, and I'll just have to pull his mouth down and shove the bottle in. Or once you take the bottle out, it's harder to get him going again. That's why I'm afraid to take it out when it's time to burp. I'm afraid he might not start again. So just examples of parents like they're feeling that stress and that pressure and that anxiety, and so they're ignoring some of those cues from infants. And at 1 year, fewer than half of former NICU families enjoyed feeding times. So it does kind of represent that feeding difficulties, feeding stress really impacts families. Parental attitudes that focus on food rather than the child can lead to impaired feeding interactions. So like I just said, if we're so focused on these volumes and calories and all this stuff, and the food that they're eating or not eating can really impact that dynamic. And then parent-child interactions during meals is predictive of selective eating and food refusal as they get older. So using like what they call coercive and controlling prompts, which includes bribing, threatening, consequences, were associated with more food refusal. And then we have COVID-19, which didn't help with really anything for anyone, but it certainly did not help feeding either. So what the research has been showing as far as the impacts of COVID-19 on feeding practices is that this probably isn't surprising to anyone, but the use of structure and rules around meals really decreased during the pandemic. And the more parent negative mood during COVID-19 or higher negative parent mood was associated with higher levels of using those coercive, controlling, and so like bribing, threatening, as well as indulgence, which means like a lot more of like children grazing and snacking throughout the day rather than having those structured meals. So that does not help for children who already have feeding difficulties. And then this is a kind of a food selectivity parent-child interaction cycle that I, along with a colleague, have been working on. And so essentially, this is the dynamic that just over and over again presents itself. And it is when a parent presents a new food. So if we take a child who has autism and they're very rigid about the foods that they eat, then let's say a parent presents a new food to them. Maybe it's a carrot and they put it in front of them. The child refuses, and that can look a lot of different ways. Maybe the child tantrums, they get up from the table, they gag. Maybe they start to eat it, but they gag, or they gag at the smell. They push the plate away. Maybe they start engaging in aggression or yelling or things like that. Well, what happens is parents often try to negotiate. They try to change the expectation. So, okay, just lick it or just take one bite. They might offer bribes or threaten punishment. Typically, they respond inconsistently in different situations. And what's going to happen is they're going to go back and forth for a while, escalating, escalating, escalating. Finally, the parent is so frustrated, they take away the new food and they have to have their child eat, right? So they're so stressed, their child has to eat. So then they present the child's preferred foods, the foods that the child's stuck on. And so the child stops their tantrum, they eat the preferred foods. And then what happens is the mealtime chaos subsides, parental stress decreases in the short term. And then some parents are going to be less likely to keep presenting foods because of all of this, or they continue and the cycle just kind of keeps on going. And then the outcomes of this is that caregivers experience concern, discouragement, frustration, lots of negative emotions. They learn that they can avoid the stress at meals by not offering new foods, putting demands in place around meal times. The child learns how to effectively avoid new foods. And then the child often has less exposure to new foods outside of their limited variety. And this really contributes to the durability of food selectivity over time. So with feeding disorders and food selectivity, often foods start falling off and they get more and more selective over time, not less, except for with intervention. So looking at feeding disorders and autism, children with autism are 5 times more likely than their neurotypical peers to have a feeding disorder. And there's a lot of contributing factors to that. One of them can be sensory challenges. Motor delays can apply to oral motor skills as well. A lot of internalizing and externalizing behavior, so that anxiety, behavior problems. And one of the biggest one is rigidity around mealtime rituals and routines and foods. So the rigidity is one of the hardest things to treat and for parents to manage because it is very strong. I have kids who they will only eat the rainbow goldfish, but only the ones that look like the regular goldfish, the orange goldfish, but only from the rainbow goldfish package. They won't eat the regular goldfish. And that could I could give you 27 examples very similar to that. Only drinking from certain cups, only eating certain things at school, but not at home, or vice versa. There's a lot of GI concerns within the autism population. So children with autism are more likely than their peers to be hospitalized for GI conditions like abdominal pain, constipation. That can really impact feeding because of discomfort, tolerance, things like that. Sometimes parent dietary preferences can impact feeding if parents are eliminating certain foods based on information they've read or been given. But it's not usually a big factor. And then challenges with attention and adaptive skills can be a pretty big one. So kids with autism often aren't necessarily self-feeding like their peers, or they're not their attention difficulties make it difficult for them to sit for long periods of time. They're not sitting at the table for meals, things like that. So some very common concerns, most common concern from parents for kids with autism for feeding is limited variety. Sometimes it's unmanaged constipation or they're not taking their medication. Sometimes it's not using age-appropriate skills. So you'll have a 4, 5, or 6-year-old still drinking from a baby bottle, or an 8-year-old that's not self-feeding, things like that. And then again, a lot of mealtime behaviors. And then parents of autistic children with food selectivity in a study in 2015 interestingly reported more severe autism symptoms and behavior problems, as well as higher parental stress compared to parents of autistic children without food selectivity. And what's interesting is there were no differences in clinician rating of autism symptom severity. So these children were paired based on symptom severity, but parents that had a child with food selectivity reported more severe autism symptoms. So it's interesting that it affects parents' perception of like their general symptoms based on the food selectivity piece. And there were no differences in the study in ratings of adaptive skills. But it is interesting to me because, when you think about feeding, it's something that's really challenging to escape. So parents of children with autism can avoid and prevent some things. They can avoid and prevent some tantrums, whether that's like using good preventative strategies or like giving in and things like that. But meals and feeding, you have to do it multiple times a day. There's really no escaping it. So if it's challenging, you're going to be dealing with that like over and over again. So it's very, very stressful for parents, and that's why sometimes it can feel very overwhelming. And while many people would love their family meals to look like the first picture, a lot of times it doesn't look that way. So moving on a little bit to really my research of where I focused is measuring the developmental progress of children in the intensive feeding program. So how this started is really I, along with other providers, started realizing, and parents were reporting that they were observing their children in the intensive feeding program. So, again, they're there for 8 weeks, making huge, broader developmental progress during the program. So, the child's only focused on feeding. So, it's this weird little unique situation where this child's kind of in this bubble. They're not doing other therapies, they're not in school, they're really focused on these feeding skills primarily. And parents were saying they're talking so much more and they've started walking, which we've been working on forever, or different things. And so we wanted to start capturing some of this and seeing if this qualitative information we were getting we were able to measure it or capture it. And then I'm also very interested in the improvement in parent stress and parent-child relationship. So why would we think that feeding difficulties might impact overall development? I mean, one thing for sure, nutritional deficits, right? So if a child is eating better or eating healthier foods, it's definitely going to impact their fatigue, their energy level, sleep, a lot of things that are going to help their brain learn and grow and have the attention and all of those pieces. Although we have lots of kids that are tube fed, so they are getting quality nutrition when they come to the intensive program. So it definitely cannot explain all of it. Other reasons we think is that a lot of feeding difficulties can limit a child's social activities or ability to engage in as many opportunities for development. And I think one of the biggest ones is really all of the research that shows that impairment in the parent-child relationship, parent stress, behaviors at meals, and all of those different things. And so that would be one of my biggest theories as to why feeding difficulties, why treating feeding difficulties could impact development in a more large way. And these impacts might be more severe for populations that are already impacted by maybe atypical or delayed development. So that was really our hypotheses, and then why we believed that the parent-child relationship was improving during their time in the feeding treatment program was this increased one-on-one time. So the caregiver is there with the child all the time, which might not be typical for their daily life. They have developmental support. We noticed parent perspective shifting a lot in the program, noticing child's, it's like very similar to a lot of behavioral and parent training programs. Parents are noticing more positive things that their child's doing, how hard their child's working, maybe learning with the psychoeducation how challenging feeding is for their child. They're getting behavioral training and coaching hands-on. They're starting to feel more empowered. They're collaborating. They're feeling more confident. They're agreeing more with their partner or other caregivers. And they also have the opportunity to be paired with a parent mentor when they enter the program or before the program. So they're starting to feel, I think, a little bit more community support and things like that as well. So I think there's a lot of reasons that parents from the parent side might be able to engage in that parent-child relationship better, and the child's gaining confidence through what they're doing in the feeding program, as well as what they're getting from their parent through that as well. So our main research question was, do children in the intensive feeding program make significant developmental gains across areas during the 8-week program? And then our next question, and this is what we're starting to explore even more, is this developmental progress greater than these children will make during an 8-week period, not in the intensive feeding program? So it's great if they're making gains. That's definitely exciting. But is it greater than what we would expect in a typical 2-month period? So where we started was simply at when they started the program and when they finished the program, parents completed, this is all online, parents completed the developmental profile for DP4. So it measures physical, adaptive behavior, social, emotional, cognitive, and communication. And then they filled out measures on other constructs like the parent-child relationship, feeding difficulties, the family and parent stress related to feeding, the feeding impact on the family, and then general behavior. And I'm not going to go through this in detail, but I can pull the slide back up at the end if we have questions. But these are more about the measures that I used, and I'm using in some example questions as well. So some more information about the demographics. So far, we've had about 51 children go through the intensive program in this study. There's 8 children in the program at a time, so it's been running for about over a year and a half. The average age of children in this study is 4 years and 9 months. A little bit more heavy males than females, which is pretty typical of the population too. And then race ethnicity, definitely the highest percentage are white, non-Hispanic, but we do have a pretty large Somali and Nepali population as well. So we do have some different diverse races and ethnicities in the program. Here's our percentage of neurotypical children versus children with some form of developmental delays. And you can see the blue is the developmental delay. So most of them in the intensive feeding program do have some developmental delay. And then if you break it down by type, you can see the blue is autism on the right. So a very large percentage of our children have autism. There's CP. A couple of things to note is the purple is other or multiple. So some of those children also have autism. And then the green is prematurity. And that's a lot of our younger kids who don't really have a diagnosis quite yet. They definitely have some developmental delays, and a decent portion of them will likely be diagnosed with autism as well. So all of that to say, a large percentage of our population that we work with, that's also true on the outpatient side as well, do have autism and definitely developmental disabilities in some form. So here's some of the preliminary developmental results. And so these are averages across time 1 and time 2. So again, when they enter the program is the tan bar, and when they leave the program is the blue bar across these different developmental skills, and then the percentiles on the left. So you can see that on average, children are making pretty big gains in a variety of areas. You can see adaptive skills, communication, physical, social, emotional are all pretty large, and those 4 are significant. Cognitive skills differences weren't significant, and it's kind of what we expected. That's a lot to expect to change in an 8-week period. We didn't expect to see huge changes in cognitive skills, if any, but also interesting to see changes in areas like physical skills. That's not something obviously we're targeting. And they're not in physical therapy or occupational therapy. So it is interesting to see some of these skills, whether, we can talk a little bit more later about why that might be. But and then broken down by average months of developmental growth during the intensive program. So on the bottom is the number of months. Again, this is average, but you can see some like pretty big growth with like physical skills, almost 14 months, communication, 12 months. So objectively, you might say like, well, that looks like larger than 2 months of growth, which is the time that they're there. But we do know that children grow in different ways and spurts, and it's not all linear or perfect. And so even though this was really exciting data and was showing us like what we qualitatively had expected or seen and what parents reported, we also want to keep exploring this more. I'm not going to show you all the other data that we collected, but just to give you a sense of this, this is an example from a patient. We do measure parent-child closeness. So you can see for this child that went up, which is fairly typical of a pattern we see. And then their general behavior, their negative behavior went down while their positive behavior went up a little bit. And then we have lots of other feeding measures and things that I won't go into or show you. But then this is the addition that we've started doing now. So we don't have too many children yet to run more analyses or really aggregate the data or anything. But to show you one example, this is now what we're doing is we're collecting the same DP4 8 weeks before they start intensive. So we'll be able to compare an individual child's data to their previous data. So time 1 now is 8 weeks before the program. Time 2 now would be when they start the program, and time 3 would be when they complete the program, so that we can see if during that 8-week period before we're seeing the same trend of developmental gains, or if we're seeing larger developmental gains during the program. You can see cognitive up there at the top just doing its own thing. We typically see that. But you can see some of these kind of cool differences of accelerated growth once starting the program and some of these other skills. And for this child, pretty cool. They had a larger separation between developmental skills, larger gaps there, whereas now they're a little bit closer together. Some of their developmental skills are kind of growing at a little bit closer rate, which is kind of cool to see along with the gains they've made. Okay, I'm going to go back to these videos so that they can keep recording a little bit longer. I do have some cool videos to show you, but I'm going to save that for the very end. So really where we're trying to go with this study is to examine some more like mediation and moderation models. So I really want to look at this like parent-child relationship a little bit closer. So our families that are gaining in the parent-child relationship, does that impact the developmental growth? Like trying to figure out, and at the bottom there, identify some of these key factors as to what's playing a role in why we're seeing this developmental growth. And then another big thing is, like I said, this is a unique like situation. They're in this like little nice clean bubble. But does some of the same relationship work in the outpatient and co-treatment models? So are we seeing some of these developmental gains for kids feeding on the outpatient level or co-treatment level, but not the intensive program? So I want to go into a little bit more of some key points and things to take away and talk through like practical applications a little bit more. So to start with, just because a child does not have low weight does not mean they're meeting their nutritional needs. So keep that in mind when you're working with children with autism, other developmental disorders and disabilities. A lot of them are going to actually be just fine on the growth chart. So that means that their pediatrician might not have concerns. That might mean that parents don't bring it up as much. But that doesn't mean that, number one, meal times are going well or are pleasant for the family, or that's eating at school is going well. And it doesn't mean that they're nutritionally like doing well. I have one patient that I've worked with. When I first saw him, for 6 years, he ate only chocolate chip cookies and chocolate milk. That was it. No other food or drink. And he was weight-wise, growth-wise, just fine. But obviously, as anyone can assume, he was missing so many nutrients from his diet and having a ton of like behavioral health concerns and anxiety and things like that, which doesn't mean that's all coming from nutrition, but it definitely doesn't help. Feeding, like we talked about, is not simply a task or a daily activity. So sometimes that can be the view is like, we just got to get through these meals, make sure the kids eat, those types of things. But this is actually like a relationship, situation. This is a dynamic. And it starts from the very beginning. So figuring out a little bit more of a child's feeding history and how stressful it was for a parent from the beginning can be really helpful. And then remembering that autistic children are 5 times more likely to have a feeding disorder. And this actually can be one of the first signs of autism. There are many, many times where feeding difficulties, either regression in feeding, or just really a lot of transitions with feeding were really challenging. Transitioning off the bottle, transitioning to purees, transitioning to solids. Like if a child was having difficulties at all those stages, that's definitely an interesting sign that obviously, along with many other things, can be a sign of autism. We have refer kids very often for autism assessments when they're in the intensive feeding program or when one of us starts seeing them for feeding, and that's the first time a parent has even heard that that's a concern. So it is interesting how early some of this rigidity and things around feeding starts. And then really remembering with who you're working with, these parents with children with feeding disorders are experiencing a ton of increased stress related to their child's feeding. And they might even be perceiving their child's symptoms as more severe. And I think that that has a lot of good information for us as far as where we start with different treatments. And so deciding if treating feeding is a priority can be helpful depending on how much stress it's really causing for the family, and are they even able to focus on some other things, because 3 to 6 times a day they're really overwhelmed with feeding their child or getting their child to eat. Treating feeding difficulties can significantly impact family functioning, and this actually might generalize to other behavioral challenges. So I think generally the idea is, well, let's treat some of these general things, and that's probably going to impact some of these other areas like feeding or sleep or some of these other kind of like smaller specialty areas. But actually, sometimes it makes sense to start with something that's really causing a lot of distress for the family, target that, and these things will really start to generalize too. So that's kind of what we're starting to see more and more of. And then knowing that treating feeding difficulties may lead to overall improvements in their general development in these areas that you're not really targeting, like communication or social emotional skills and things like that. So then a little bit more about practical applications. It's really important to regularly assess for feeding difficulties and parental stress related to meal times and feeding. Here's some specific questions, just examples, because a lot of times, like I'll see in a pediatrician note, like nutrition adequate or fine. If you ask some general questions, sometimes you're not going to get a lot of answers, whether it's because it's just become so normal to families or there aren't weight concerns. But a couple that I really like is just, do you worry about your child's eating? It's just really basic, simple, and it allows the parent to like say if it's something they've been worried about. Does your child eat consistently from all food groups can be helpful. You can also ask things like, is your child really specific about the things that they eat? Does your child have a meal schedule, or do they snack throughout the day is a really good one to get at snacking and grazing. Does your child eat the way that other children their age eat? Can hit on a bunch of different areas. It's a great question. So it can hit on things like, no, my child's still drinking from a bottle. It can be, no, my child drinks Pediatric and they don't really eat very much. No, they only eat with their hands. They won't use silverware. Those types of things. So it can really get like questions that can target like a large range of things that a parent can bring up. And then one big one that I think can help with deciding where to start with treatment is, do meal times feel more stressful than non-meal times for your family? Or does your child have more tantrums at meals compared to other times of the day? So again, if we're just having stress across the whole day, we're having tons of behavior problems, then maybe it doesn't make the most sense to target meals first. Obviously, there's a lot of factors that go into that. But if parents are reporting that, no, this is like the most stressful time of the day and we're having significantly more behaviors at meals, which is common, then that might make sense to target that. And then something to keep in mind is that really small changes can actually make really big differences with feeding, and they can be included in any behavioral plan or parent training program that you're using or doing. Some just like really simple changes that can make a huge difference with the child's eating is eliminating grazing and having a meal schedule. That's like pretty much the first place to start always. So kids that are filling up on juice, milk, snack foods, things like that, are going to be very unlikely to sit down at the table and have a meal, to try anything new, to try anything challenging, because they're constantly full or at least not really getting hungry. And that's really important. Having like appetite, our appetite go like this is super important. And parents often sometimes use snacks as like a behavior modification tool. Or like to avoid tantrums, or what happens is parents are very afraid of their child not eating, and they think that meals must consist of healthy foods. And so then that means that snacks are when the kid gets to eat their preferred foods. In reality, what's happening is that kids typically aren't eating what the family's presenting, right? They're not eating the grilled chicken and mashed potatoes and asparagus that the family keeps putting in front of them for dinner every single night. Parents get really stuck on breakfast. Like, well, he doesn't eat any breakfast food, so like we don't have anything to give him at breakfast. So one of the things that, if I can kind of like takeaways, is really like try to break down some of these ideas that parents hold about what can be served when, and all of these things. If a child is only eating goldfish, let's see, those like little Debbie cakes, so I'm drawing from an experience I just had this week, and French fries, they're only eating those three foods. That's actually what their meals and snacks should consist of. So I'm not asking them in the beginning to change the foods they're offering. And I'm actually, if anything, I'm asking them to start with stopping offering those new foods and variety. It's not forever, but right now they're in that cycle, like I talked about, where they're refusing over and over again these new foods, and then they're getting their preferred foods anyway, but they're getting them throughout the day, so everything's chaotic. So instead, what I start with is ask them to only serve their preferred foods, but do it at meals and snacks, and having them get over this idea of it can only be a breakfast food or it must be a dinner food. No, if they only have three foods that they eat, then those are their foods that they're going to be eating at meals. So they're going to have Little Debbie, goldfish, and fries at breakfast, lunch, dinner, and because that's what they're eating anyway. So parents typically have a hard time with that because they're like, but then they're not eating a variety. And so I'm like, but are they eating that right now? And usually the answer is no. Or I sometimes ask, well, what percentage of the time do they eat that food that you put in front of them? If the answer is like high, then okay, maybe we don't change it in that way. But usually the answer is like 0% or 1%. Then let's stop and break those habits, and let's just work on the meal schedule first and appetite regulation and things like that. So that's kind of like a really easy starting point. Then working on eating meals at the table and an appropriate seat. That's a huge thing that can make or a small thing that can make a really huge difference. You'd be surprised at how often like a booster seat with straps can really improve meal times, just because the child has to be sitting there. So that's a very easy thing. Using a reward system, a simple reward system for finishing a meal or trying a small taste of a new food, if a child's ready for that kind of a step, can be really big, and make really big changes. And then really coaching the parents like you would with any other behavioral parent training or things like that of just how to utilize praise and selective attention effectively at meal times or around food. Again, parents get very stressed, very anxious about a child's feeding and eating. And so that stress and anxiety can really play a part. The child gags and the parent's reacting dramatically, or the child's having a tantrum and the parent is, again, responding to that in different ways, whether it's bringing out the preferred foods or parent escalating. So, truly just coaching the parents through meal times can be very, very effective just related to how they're using their attention. So those are just a few, like, obviously there's a lot of steps to feeding treatment and there's a lot of complicating factors and things to think about, but just some of those really simple changes to start with can make a really big difference for a kid with feeding difficulties. And then when thinking about referrals and consultation to their relevant providers, um, thinking and prioritizing what's really interfering with them eating. So feeding therapists, which are again usually like OT or SLP trained in feeding, they work on skills. So like chewing skills, maybe drinking out of a certain device, self-feeding. That's great if you have a pretty semi-compliant kid and they really just need to work on their skill. However, let's say you have a ton of behaviors that are really interfering with meals. Even if you have skill deficits, usually they're going to need to work on some of those behaviors and work with psychology or a behavioral provider first to work on some of those behaviors of acceptance, tolerating new foods in front of them, a bunch of other things before they're even able to fully participate. Or sometimes we do collaborative sessions if that's something that you're in a situation you could do with again, like a feeding therapist and a psychologist can be a really useful team. And then thinking about like the medical and dietitian piece of it to support with like the nutritional deficits, constipation, all of those different pieces, what formula they should be on, if any, those types of things. A couple resources. So if you're looking for a good book for yourself or to recommend to parents, Broccoli Bootcamp is one of my favorites. It's a really quality book about selective eaters. A lot of it really applies for children with autism. And if you have a pretty savvy parent that can navigate resources pretty well and likes to, read books and can apply them and stuff, it's great for a parent. It is they are able to use it. But even just as a provider, I would say it's a very helpful book. And then if you're looking for measures to further assess feeding difficulties, the infantfeedingcare.com has a lot of really great measures that I used in this study and use often. And then a new one that I've been using is the Feeding and Swallowing Impact Survey, which is kind of like a quality of life for families related to feeding, which is a really good one as well. I'm going to go back to the videos now. So I have a couple disclaimers, and then I know somebody was going to turn the recording off as well, so I can show them. So a couple disclaimers. I have